Well, thank you, and thank all of y'all for being here, and thank you for having us. I'm honored to be with my esteemed colleagues here in the Doctors Caucus. And for those of you who aren't familiar, we do have a Doctors Caucus in Congress, and we have quite a few physicians, and um, and I believe we only have two pharmacists in Congress. I don't know of a third one, but nevertheless, for many years, I was the only pharmacist in Congress. In fact, the only pharmacist that served since the early 70s. But when I was the only pharmacist in Congress, one of my colleagues had given me the hashtag OPIC to mean only pharmacist in Congress. Well, now, of course, we've got Diana Harshbarger who's doing a great job, and she's in Congress now. So my colleague told me, he said, you can continue to use the hashtag OPIC, but now it means oldest pharmacist. So much for that. But I am honored to be here, and as you heard in the introduction, I've served at many levels. I started when I was 10, by the way, so that explains how I've served so many ways. But nevertheless, one of the main focuses that I have, obviously, as a member of Congress, has been to address prescription drug pricing, and that's something that is very dear to me and very important to me because I practiced independent retail pharmacy for 32 years, as you heard. I had my own business. And I was the one who had to go to the counter and tell the senior citizen how much their prescription was. I was the one who watched the senior citizens try to make a decision between buying groceries and buying medicine. I was the one who had to go to the counter and tell the mother how much the antibiotic was for her child and watch her in tears as she tried to figure out how she was going to pay for that antibiotic. And I set as my goal to do something about that because I know there's a problem. You know, Jim just mentioned Teddy Roosevelt, and Teddy Roosevelt's one of my favorites, and favorite presidents and favorite members of our favorite person in history. And the reason for that is because Teddy Roosevelt, he would bust it up. He busted up a lot of the monopolies that existed during the time, and we need him back again because the drug pricing system is a monopoly now. We've got 3 pharmacy benefit managers, PBMs, that control 80% of the market. We've got 3 group purchasing organizations that control 80% of the market. And that's not the kind of competition we need. And I've set as my goal to do something about that. Now, let me just preface this by saying there's no question that pharmaceutical manufacturers need to do a better job with their pricing. But the real problem lies within the drug pricing system that is the vertical integration that exists there, where you've got the insurance company that owns the pharmacy benefit manager, that owns the group purchasing organization, that owns the pharmacy, that owns the doctor. Did you know who the largest employer of physicians in America is right now? United Healthcare. An insurance company employs more physicians than anybody else in the country. Now, there's nothing wrong with working for United Healthcare, but I would submit to you that with almost 9% of all physicians in America working for an insurance company, there's a problem there. And I will be just quite frank with you. No insurance company should own a PBM, and no PBM should own a pharmacy. They need to be busted up. They need to be regulated like that. Now, I'm not big on regulations, and look, I get it. I know we live in a capitalistic society, and I know that you know, we all want to be successful. We all want to make money. I opened my own business because I wanted to serve patients, but I also wanted to be successful financially. But this is what is happening here with the PBMs is out of control. It is causing prescription drug prices to be too high to where people can't afford it. And I'll say one more thing about it. You know, all of us, whether you're a Republican, a Democrat, or independent, we all want the same thing when it comes to health care. We want affordable, accessible, quality health care. Democrats want that, Republicans want that, independents want that. Accessible, affordable, quality health care. And we can only get that through competition. That's what's going to happen. And we don't have enough competition right now, and this has got to be something that's busted up. Now, I'll yield right now and let my colleagues go on, but I've got a lot more to say. I could speak all day about this. As many of you know, it is my passion. But again, if you've experienced what I experienced for 40 years going up to that counter and telling patients how much their prescription was going to cost them, then you feel the same way I feel.
Okay.
First of all, thank you, Jim Conselman, for having us here today. I also want to introduce my staff member, my Deputy Chief of Staff, and my Senior Health Advisor, Matt Tucker, who's been with me since 2 days before I was sworn in, is here today as well. So I'm going to pivot on the introduction that Buddy just gave and talk about affordability and accessibility. My district in South Central Pennsylvania includes beautiful Gettysburg. I encourage all of you to come there. It goes right up to the Flight 93 Memorial. It's a very important day that we just memorialized yesterday with the history. But my district is mostly served by physicians who treat Medicare patients. And we're up against the wall when it comes to Medicare reimbursement right now. My wife continues to practice and is right now in the office seeing patients as we speak. But Medicare reimbursement has failed to keep up with what the practices require to keep the doors open, to keep the nurses paid, to keep the lights on. And I'm going to specifically talk about those reimbursements and how that affects access to care. So I talked to Allie about how the practice is going, how she continues to maintain things. And she's actually limiting the number of Medicare patients that she sees because of the diminishing reimbursement from Medicare. And so I asked her this past weekend, how many Medicare patients are you seeing? Well, how do you limit that? She said new patients that come in, it has to be 1 in 4 or we can't continue to do this. Cost of providing the equipment, cost of employing the staff has continued to rise. Yet Medicare reimbursement continues to be a falling number. And on top of that, we have the medical inflation that continues to occur. And that medical inflation means that, yes, the employees are paid at a higher rate. The medical products that are used in the practice continue to rise in price. And so with that, 1 in 4 is all they're able to really adequately. They need patients who have ERISA plans, who have outside insurance, or their fee-for-service, and that will come in and pay to see a physician. Now, as an aging population that the practice continues to serve, and that's not just in South Central Pennsylvania, that's throughout the United States, that we're seeing an aging population and more people dependent on that Medicare to be able to be accessible and to be their primary insurance. And it's not going to be there. It's forcing some physicians to limit, as in the case of my wife, or to exclude Medicare patients from their practices. Greg Murphy and I just had a discussion. The dermatologists were on the Hill this week. They did their fly-in, met with many dermatologists. I practiced derm for 25 years and talked to many of these young dermatologists. They come out of practice, what do they want to do? Cosmetics. Sign up for the Botox. We don't have to deal with insurance. Medicare. We don't take Medicare patients. We'll do injections. We'll take care of all the cosmetics, and that is a very lucrative and successful way to practice. But let's face it, that's not what you train to do. You train to treat patients with melanoma. You train to treat patients with inflammatory skin diseases, and you're going to see that there are going to be fewer doctors, and I'll specifically talk about dermatology. There are going to be fewer doctors who are going to be accessible. Call your dermatologist. Greg, how long how long to get an appointment? Because we were doing a curbside.
Next May.
Next May to get an appointment.
I got a little finger.
That's called your nose, sir. So I just want to, I love using props. And so this is my prop for today. I went downstairs to the grill room. You all love the grill room. There's no dogs or cats on the menu. I checked. Maybe not. So let's look at what the cost of the CHC club sandwich, $19. So if that is what we were looking at when we came into office, that used to cost $16. So if Medicare was determining this fee schedule, they would say that 6 years ago when I came here, that's $16. That would be compensated now at $13.50. But inflation, the cost of the servers who provide the great service here at the CHC, the cost of the roasted turkey, the cheddar cheese has all increased. So the CHC has had to increase the price of that. But if you're a Medicare provider, you can't increase that price. You're obligated by federal law, you're obligated to take that Medicare reimbursement rate, and you're obligated to accept that and charge the 20% copay that goes along to that. You can't charge on top of that. So you have no capabilities of dealing with the Medicare reimbursement rate. And there's no adjustment for the inflation that has continued to occur. So there are issues that I think that we can address. And one is the budget neutrality threshold for code adjustments. And that's a lot of jargon that says that each year the fee schedule comes out for Medicare patients, and that's the budget neutrality threshold. And that says that those compensations go down, and they've gone down sequentially for the last 10 years, and the reimbursement continues to fall. So the club sandwich costs less, it is reimbursed less and less each year, and that needs to be eliminated. We need to be able to address that. Or you're not going to have patients having access to physicians for their care unless the physician is adequately compensated. You can't guide the market by going after the provider who has stayed with these patients through COVID, has been there, taking care of patients, and we in government have to be able to come up with a way to compensate at an adequate level. And I think that we need to eliminate the budget neutrality threshold. I think that that has to be taken away from it. And we need to be able to step up and have a positive inflation, an automatic inflationary update each year, to be able to talk about the price of the cheddar cheese and the price of the turkey and the price of the scalpel and the price of the injection. It's a simple analogy. It's a business analogy. And I think it resonates when you talk about you're going to order those club sandwiches downstairs in the grill room. I do. And you're not going to flinch at the cost of that. And we have to be able to not flinch at the ability to compensate physicians at an adequate amount of what they deserve and what keeps the doors open and what keeps the lights on. I want to talk about a second issue, and I'm going to yield to Greg Murphy. And like Buddy, I could keep you here talking healthcare all day. But the second issue is the number of physicians that are trained in the United States. I come from Pennsylvania. I went to medical school in Pennsylvania. I trained in Baltimore and had incredible opportunities. Pennsylvania has the third largest number of medical schools in the United States, and yet in my district there is an incredible physician shortage. We don't have a shortage of cows, and we have the largest number of dairy producers in the Northeast, but we have a shortage of doctors. When I campaigned the first time, and I would sit down with hospital boards and pharmacists, and I would always walk away because my district is huge. They go, you seem like you're going to be an okay guy. You're never going to win this seat, but here's an application to come on staff. We need you. You're board certified in internal medicine. We need you on our staff. So after that election, come back, and I collected 17 applications. So when we came down on day one, the first meeting with Matt Tucker that we had was a discussion of how can we expand bringing physicians into South Central Pennsylvania, a beautiful area where you can ski. We have 5 ski resorts, 4 of them owned by Vail. You can fish, you can hunt. It's close to Philadelphia, it's close to Washington, D.C., but we don't have doctors. We don't have young people who are from this area because they go to Philadelphia and Pittsburgh and they don't stay in the rural areas. So we initiated a program with one of the medical schools that students do their entire 3rd and 4th year in Pennsylvania's 13th Congressional District. How do you get students to come home? First of all, we went to the medical schools, we did a zip code analysis, and we reached out to the students who were from the communities and collaborated with 5 of the hospitals, including a VA hospital, which they said, you're never going to break into the VA, and we did. It took us a year to set up the program, and now it's in year 6 of the program. First year there were 12, second year there were 24, 36, and these students do their primary care rotations. They do their pediatrics, their emergency room programs within the district. And then half of them have done their residencies and stayed there because they form those alliances, those mentorships. They know who the pharmacists are. They know who the urologists are. They allow them to come home and practice in that area. Now, this is a way that do a catch and keep program, and I am a fisherman. This is not a catch and release. We want these students, the best and the brightest, to come home and be able to establish their medical careers here. Like my colleagues here, I am a fiscal conservative. This has been done with, hey Matt, how much federal money did we put into this program? $0, nothing. we sat down, I sat down with the VA, and initially they weren't interested in having the medical students there. It's going to be hard to get them in. But I knew the director because I had been on staff there. And I sat down with her, and it was after Super Bowl Sunday, and they had done a Super Bowl ad at $2.3 million to recruit physicians. And I said to her, phone's ringing off the hook? You're getting doctors calling all day. They want to come and work at the VA. She goes, yeah, I don't think that was a good expenditure of money. I said, put housing here for them. Allow the students to live here so they don't have to pay rent. If they're too far away from their homes, allow them to be here. She took an old maintenance building and with her in-staff used electricians, carpenters, and converted it to 6 one-bedroom, one-bath apartments, nicer than anything I ever lived in Hopkins, certainly nicer than anything I ever lived in Philadelphia. But it didn't fill. First year that they were there, she had open rooms and abilities. She wanted more students there. So she came back to me and goes, this isn't working. How do we fill it? I said, feed them. Give them meal passes to the cafeteria. There is a waiting list right now because the students love taking care of the veterans. They like the housing that they have. They like the meal passes. And then they gave them gym passes to the local Planet Fitness. So these students are assimilating into the community, and they're doing their residencies here, and they're continuing to establish that. This isn't thinking outside of the box. Matt and I sat down and came up with this plan, thinking within the box, thinking within Pennsylvania 13. And I think that that's what we, as Republican physician legislators, I think that's what we do. As Republican members of the Doc Caucus, with pharmacists, with podiatrists, with nurse practitioners, I think that's what we bring to the table. And I think it's important that, and I'll conclude with this, the framers of the Constitution were not all lawyers. The framers included Benjamin Russ, who was the father of American psychiatry, who founded Pennsylvania Hospital, the first physician-owned hospital in the United States. I think we bring something to the table as healthcare providers, and I think that you're going to see as we move forward with the Doc Caucus that there's going to be more ideas brought forward, there's going to be more collaboration, and I look forward to your input to doing that. And with that, I will turn it over to one of 2 urologists in the United States House of, and oh yeah, you can say that, my colleague Greg Murphy.
Thank you, guys. Thank you, everybody, this morning. I'm going to point out McLean Piner. I've known McLean a little longer than you've known your health staffer. I've actually known him since he was born. His parents were 2 blocks away, and McLean has been with me actually in the State House and here, and has been a fantastic, fantastic healthcare worker. Guys, I want to talk a little bit. I'll talk about 3 separate items and actually try to kind of pull everything together. Our Docs Caucus meets every Thursday morning. It's probably the most active caucus in D.C., and we have a camaraderie and a synergy of some really smart people, excluding yours truly, because urologists aren't that smart, or else we would have picked another field. But I think we really have something to bring to Congress, because guess what? We've spent our lives dedicated to being and taking care of patients. Every single individual in here will be a patient. I was one 3 months ago. And it matters in every way to each of us how we get health care, how it's delivered, how we can afford it, how accessible it is, and so many different things. You know, Jason Smith, our chair of Ways and Means, he throws his hands up, he goes, I just don't get health care. And I just said, well, welcome to the club. We have so many hands in the pockets of what's going on in healthcare here in the United States. I've done a lot of work abroad in many different countries and been able to see what folks do in other countries. And we have the greatest and the absolute most disastrous healthcare system here in the United States. Buddy was talking about pharmacy and all the pharmacy benefit managers that suck out money from the middle stream. Personally, I'm working with some pharmaceutical companies. In the IRA, there was a provision that is a 913 provision where small molecules, which are the pills that we take for cancer, are now being run out of business, or their patent runs out in 9 years. Remember, when your molecule starts, or when you first develop the molecule, that's when the clock starts. And so the IRA said, well, after 9 years, you have to give it up. Well, 180 drugs now have been taken offline clinically because you can't make money. You can't get your reinvestment back. And there's one particular prostate cancer drug that I've used for 15 years now that has 5 different now considerations, indications for what it is. Keytruda, you see the ads. By the way, direct consumer advertising, one of my pet peeves. I have never, ever, ever prescribed a drug because a patient came in and said, hey, I saw a drug on television. I did have one patient come in and unwrap a little article and said, yeah, see, I got this drug. This is the best one, you know, boom, boom, boom. And I said, it's a great drug. And they looked at me with this little smug look and said, yeah. I said, there's just one problem. What's that, doc? I said, you don't have this disease. And so, this is, I'm trying to help our pharmaceutical companies because we're the most innovative drug companies in the world. We cure people, but our costs are too high. And there's no reason, in my opinion, we're one of 2 countries in the world that have direct-to-consumer advertising. Anybody want to guess the other one? New Zealand, where there are 4 million people and 25 million sheep. Who are they advertising to? And so we have to get drug costs down, and there has to be buy-in by everybody at every step of the pool. We're pulling money in. Secondly, you guys, if you're in insurance, not insurance, and you're driving down to North Carolina, which has the great Outer Banks, who's been to the Outer Banks? All right, great, cool. That's I'm blessed. I get to go to the beach in my district. So does Buddy, but our beaches are better. But you're driving down there. God forbid you have a kidney stone. You go to the hospital. Unfortunately, you have to have it taken out. Oops, but you're not in network, so you get a surprise bill. And we worked on this, and we passed out a bipartisan, bicameral bill signed by President Trump. And this has been my greatest sorrow of coming to Washington, D.C. The agencies said, forget what the law says. We're going to do this way. Thank God we had the Chevron doctrine, and it's going to pull back, I think, some of the power actually to this legislative body. We're now submitting a correction to the surprise billing, and again, bipartisan, bicameral support to really allow patients not to be involved and actually let insurance companies and those who deliver the care bargain fairly. And then finally, I'll just kind of follow up with what John just said about medical education. Medicare adds 10,000 people a day to the roll. And I've spit out this statistic a lot. In 1965, the average life expectancy was 70. Now we're up into our 80s, so you add another decade of care. But in 1965, there were 4.6 individuals paying in for one recipient. That number has dropped down to 2.6, 2.8. So the math doesn't work. And so we're trying to find a way to say, hey, how do we pay for these people? But then on the other hand, how do we actually have doctors that are going to take Medicare? It doesn't pay the bills. I've had patients come in once they get their bill. God forbid, I took their bladder out, made them a new one. They're in the hospital 6-7 days, and they came in and they apologized to me for what Medicare pays. It's kind of hard to get on your soapbox about physician pay because, you know what? There are folks that drive around Maseratis. They're usually dermatologists. But there are some urologists that do it, but that's a different thing. But it's hard, but it is causing a transformation in American medicine for employment. As John pointed out, the largest employer is an insurance company. In my opinion, the most efficient delivery of care is private practice. Because guess what? They're going to be attentive to your needs. It's not now where hospital employment, insurance employment, it's 5 o'clock, I got to go. Or I'm not going to get up at 2 o'clock in the middle of the night to take care of folks. We're having a generational gap, and this is just not with medicine, but I think we see it in so many ways. The work ethic, the ownership of patients being put forth, and the theology of this in medical schools is not good. It's not good. And I fear we have such a critical shortage now that in a decade, it's going to be not better, but worse. And so we all are working on this. And again, this is a synergistic effort where we have a lot of smart minds that are trying to grasp all the things that are going on in medicine. We have the best medicine in the world, but it's the most damn chaotic it can be. And it's up to us to bring some coherence and some sense to all of this that make it affordable, accessible, and as Buddy said, quality care. Thank you all. I'll yield back.
All right. Yes, Buddy, of course you could
If I could just follow up on something, because I think what Greg just said is extremely important. The prescription drug portion of the IRA, I've served in the Georgia State Legislature for 10 years and now in Congress for 10 years. That is the worst legislation I've ever seen, bar none. Even the CBO has said that it will result in fewer cures coming to market. Fewer cures coming to market. Look, I practiced pharmacy for over 40 years. I saw nothing short of miracles as a result of research and development. So the cures that are not going to come, what was it, Jack? The University of Chicago said it would result in 139 fewer drugs coming to market. And already we've seen 180 that,
180
drop off. Look, yeah, pharmaceutical manufacturers need to do a better job with their pricing, but at least they're putting money back into research and development. PBMs aren't putting any money. Insurance companies aren't putting any money back into research and development.
I'd like to talk about the IRA, since that came into the conversation. There is a legislative fix to that, and that is the Orphan Cures Act, which is a piece of legislation, bipartisan legislation, that makes that fix to the IRA, that allows the clock to be reset when the indication occurs for a new drug. And we have sat down with pharmaceutical manufacturers who say, look, we have something that probably can go through phase 3 trials and come to market, but it's for an orphan disease. And we're going to wait until it has broader appeal and ability to treat something like metastatic lung cancer or metastatic colon cancer. But that gallbladder cancer indication, it's not going to allow us to recoup the research and development, the innovation, which is so important to American medicine. American medicine is a cornerstone of it. It should be the innovation, because as Greg and Buddy have pointed out, that innovation is an important part, and it is an expectation in Americans. I graduated from medical school the year that the Orphan Drug Act was passed, and saw the cures, the ability to see metastatic melanoma being cured. Jimmy Carter, who's going to be the oldest living president ever, was diagnosed before I came to Congress with metastatic melanoma. They showed the imaging in the copies of his brain scans in the New York Times. You could see it from across the room. That used to be a death sentence. When I sat down with patients and felt the palpable nodes and then did the imaging and saw that, they quickly went from a surgical evaluation to a hospice evaluation. Now they see a medical oncologist and they have a potential for cure, but we are severing that potential for cures by that stipulation in the IRA. And we are working, we have a handful. Matt, there are 5 Democrats who have signed on to the Orphan Care Act. There are 5 that are with us with that 5. And we've sat down and talked to them, but it is their cornerstone legislation, and they will acknowledge that that is, I presented, it's a glitch. It's not changing what's occurring, but it is negatively impacting the cures that are being developed right now. And it's having pharmaceuticals turn away, because that shot clock needs to be reset when a new indication occurs. And I think we have the capabilities of doing that with one small fix to that legislation.